Hello, everyone. This is Mallory Caldarella from Samba Management Team, and I will be hosting tonight's webinar. Thank you for joining us this evening to discuss the roadmap to reopening your closed ASC and resuming elective surgeries. Let's start with Samba's legal disclaimer, which you will see shared on the screen. I also want to encourage you to visit Samba's website to check out our latest statement around resuming ambulatory anesthesia care. While you read through Samba's legal disclaimer, I want to mention a few quick housekeeping notes before I pass things over to Samba's president-elect and tonight's moderator. Each of you have a control panel that can be found in the upper right hand of your computer screen. Please note that this webinar is in listen-only mode. We do encourage you to submit your questions in the question box throughout the duration of the webinar. You can type in a question or comment and submit it at any time during the presentation. We will have time at the end for Q&A. If you experience any technical difficulties throughout the webinar, please submit a chat within the chat box. Our staff will monitor this and assist when necessary. I would now like to pass things over to Dr. Bassem Abdulmalik, Samba's president, for his introductory remarks.
Hello, everyone. Thank you for joining us tonight. Tonight, we're going to be discussing the number 4 of the Samba COVID-19 webinar series. And before we finish the introduction, I'm going to let you know about the number 5 that's coming up next week that we're very excited about as well. Please visit our website to read Samba's latest statement if you have not seen it yet regarding resuming ambulatory anesthesia care as our nation recovers from COVID-19. I will not go into much details as I learned that our 2 awesome speakers tonight will cover some details of that statement. If you haven't heard, we had to cancel our in-person meeting that was scheduled for May 13th to 16th in Florida because of COVID-19 travel ban and issues. But however, the board have just approved converting it into a virtual experience. And let me tell you, folks, this is not just another webinar or another Zoom. It is true virtual experience where you will be able to actually go to the virtual exhibit floor where you can mingle with exhibitors and sponsors. While you're attending a talk, you can get into a side chat. It's a kind of a side Zoom type of thing. You can talk to colleagues, discuss things, express opinions and thoughts, or even with a whole group without distracting any of the other audience. You can also have a chance to network and so forth. It's really a true virtual experience. And for a really deeply discounted price, and for members, it's a steal because there's further discount for our members. And speaking of membership, I know the majority of you are members, and I'd like to thank you for your membership and for supporting Samba. For those of you who are not members, I'd like to invite you to join us. Please visit our website to learn more about the benefits that Samba membership offers, and I'm pretty sure that you're going to be impressed. If you're not, please contact me personally. I'm happy to discuss it with you. Membership is only $250 a year. It's really worth it. The board has put together for you a Samba COVID-19 resources page on our website. This part of the website is free for all. You can have free access. So please read and share freely with all your colleagues and friends. We put that intentionally to help all those suffering and facing COVID-19 issues. There's a lot of resources out there. And one of those resources is in the webinar tab. You'll see that we have posted all the prior webinars, the recording, as well as the slides. So you can review those if you have missed 1 or 2 of them. Share them with your colleagues if you've liked one of them and you wanted to share that with them. So this is also free access for all members and non-members. We just wanted to help the whole anesthesia community of what's going on with COVID-19. Hopefully that will help us to take care of our patients and give them the best experience that they aspire and they like to see from us. Before I end my little introductory remarks, I just wanted to let you know about next week. Please mark your calendars. May 4th, 2020, we're going to have a webinar from 7 to 8:15 titled NORA in the COVID-19 era. We put together a lineup of speakers who are going to be discussing different issues with NORA. We also added another panelist to address some questions and issues. So please mark your calendars. The invitation will be coming soon. And if you have any questions in any of these areas, GI, bronchoscopy, ambulatory and NORA pediatric anesthesia, as well as IR, just feel free to send them to us in the usual fashion, and we'll be happy to address them for you during the webinar. With that, I would like to pass the mic to my friend and colleague, SAMBA President-elect Dr. Leopoldo Rodriguez, who will be moderating the session, introducing our awesome speakers. Thanks, Leo.
Thank you very much for the introduction, Bassem. For those of you who don't know me, I'm Leo Rodriguez. I live in Miami, Florida. I presented the first webinar in the series about COVID-19. And tonight, I'm honored to present to you two healthcare leaders, Dr. Michael Hicks and Dr. Stephen Geyer. I've known Dr. Hicks for many years. Dr. Hicks was previously the Regional Medical Director of HCA and is now the National Medical Director of the HCA Ambulatory Surgery Division. Dr. Hicks is also a consultant. He owns his own company. He's a principal consultant for issues about healthcare. He's also a professor at the University of North Texas about health management and policy. And he has also been very involved with the American Society of Anesthesiologists with the Practice Management Conference. When it used to be held in Texas, he was very involved in developing that conference and gave numerous presentations. I'm gonna now pass the microphone to Dr. Hicks, who I believe is one of the people that are most qualified to talk about this topic, because he has led a group of incredible leaders in HCA to really coordinate how things should be started properly. Thank you, Dr. Hicks.
Thank you, Leo. Thank you for the very kind words, and thank you for the opportunity to speak tonight to this group. It's a fascinating topic, and I believe it's something none of us ever anticipated having to go through in our careers. But regardless, we are where we are, and we're trying to make the best of it. So, Leo, once again, thank you for the opportunity, and let's get started. So, the topic tonight that I've been asked to address is a roadmap to reopening your closed ASC and resuming elective surgeries. And I'm having trouble. Okay, there we go. As Leo said, Leo did an introduction. He was, as I said, much too kind. But I am the National Medical Director for HCA's Ambulatory Surgery Division. I'm a clinical anesthesiologist, as are many of you. And I've been active in the anesthesia business and the management leadership and the practice for over 30 years. Some of you know me from my past life. I was the leader of 2 large regional or national anesthesia practices. And so I've got a lot of contacts across the country, and to prepare this presentation and in fact to prepare the strategy that we're using to reopen our surgery centers, I've drawn on both my years of experience and the folks that I know in the business. Disclosures relevant for this, as I said, National Medical Director. And in case you don't know, HCA's Ambulatory Surgery Division operates in 16 states, 39 markets, and provides care for over 800,000 patients every year, or at least it did up until the pandemic. So I like to start presentations with telling you what I hope you leave the presentation with. And so a couple of key take-home messages for tonight, in my opinion. The first one is, while we're reopening, the reality is that the COVID-19 pandemic is continuing. Because it's continuing, and we don't know exactly how it's going to play out, we're going to have to be both adaptable and resilient for some period of time into the future. As you craft your strategy for reopening, a couple of things are going to be imperative that you do. Your strategy needs to be thoughtful, needs to be programmed and agile. And once you've developed the strategy, you need to be able to rigorously apply it every case, every day, to be resilient. Resiliency in this case ensures that we have a continually safe environment that's capable of effective and efficient care, and that's what folks are depending on us to deliver. I'm going to touch briefly on some tools and resources that are available to you, but I'm only using them in ways by way of example. There are many tools and resources available. Many of them you're probably already familiar with, and so I don't want to belabor that. I do want to point out, and most of you probably already know this in your gut, but the new normal, whatever that turns out to be, is not going to be like the old normal for a while, and maybe ever again. And then if we're going to be successful, people need to feel safe if we want them to engage. And that's true not just in your surgery center and in our industry, but across the United States. We've got to create an environment where they feel safe. And if they feel safe, they'll engage and we'll move forward. Now, a disclaimer, this presentation is not a detailed roadmap, but I'm going to point you and give you some ideas about where you can get detail about how to move forward. So let's briefly revisit where we've been in the last couple of weeks and where we are. It's no surprise that we've had a significant decrease in procedural volume in the United States. A couple of reasons for that. One of them is that folks, just quite frankly, are fearful of becoming infected. An interesting but sad observation that we're making is that folks who really need to seek out care, folks that are having acute coronary events, folks who are having strokes, are not going to hospitals where they need to get treatment. They're staying home and they're suffering the consequences for it. So while we're struggling with the procedural decreases that we're seeing in our surgery centers, real folks are getting hurt really bad because they're afraid of going out into the world. Another reason why the volume has decreased is, quite frankly, there was a risk of contributing to virus spread. Bringing folks into close proximity in our centers certainly in theory could be a pathway for virus transmission. In addition to that, there was a desire that the industry recognized fairly early on, the healthcare industry as a whole, that is, that we didn't know what was coming in terms of COVID infection and disease. And so we created capacity on our hospitals, in terms of beds and ventilators and clinicians. And we did that by stopping ambulatory anesthesia cases and procedural cases in the hospital environment, but it extended over into our environment too, because we might very well have had to repurpose our centers to help with that cause. And then everyone, and a big part of the topic tonight is going to be around PPE preservation. But that was also one of the drivers for us to slow down the amount of procedural work we were doing. And then finally, and something I think that we're going to have to look back on when we have adequate time to do some forensics, is the fact that the government felt it was necessary to step in and tell us to stop. And I don't know what message that means. Maybe it was just part of a grand plan to make sure that supplies were being preserved. But some part of me thinks it might be because some of our colleagues didn't really understand the gravity of the situation and wanted to continue ahead as if nothing had changed. Where does that leave us today? Well, those changes that I just enumerated were appropriate, but the consequence of that procedural decrease is pretty profound. We've had disruptions in scheduled procedural care, and you'll note that I tend to not use the word elective. I use the word scheduled because all of the cases that we do are indicated medically, and we just have the luxury of scheduling them. An elective has this connotation that you may never get around to doing it and life is okay. And while there are probably some situations where that is a true statement, it's not true for the vast majority of the work we do. So you'll hear me use scheduled fairly consistently. These disruptions in scheduled procedural care have led to tremendous backlog of cases that are waiting to be done, and an increased fervor on folks to have return us to work so that we can start dealing with that. But there are a couple of problems. One of them is there's still some ambiguity around what is the appropriateness, the timing, and the selection of cases that can be done now and going forward. Some guidance about that has come from CMS. We'll talk about that in a minute. And then certainly the governments where you reside are the ultimate arbiters of when we're allowed to return to that. But that ambiguity still can persist. And that confusion is going to likely remain into the future for a couple of reasons, and I'll mention one of them here. It is very likely that as we reopen, both society and our centers, that we're going to see surges recur. And that may very well mean that the effort we're spending now to ramp up may have to be expended to ramp back down in some form or fashion. So as you develop your strategies, keep that in mind, that a ramping strategy is going to be very important. And then finally, and we'll touch on this in a little more detail later, all of this has led to devastating financial ramifications for health systems, for ASCs, and for us as caregivers. All of this results in a large amount of uncertainty and fear that we're going to have to address. So let's dive into it. So the initial guidance about how to restart or how to reopen comes from CMS. In a document they released just a few days ago. And the basic premise of CMS's guidance is this. There are certain gates or milestones that need to occur before the return to scheduled surgery is allowed. And in brief, there are three major gates. One is around symptoms, second is around cases, and the third is around hospital capacity. And in general, you can sum up these gates by saying, we really want to have some comfort that the bulk of the surge in this pandemic is behind us. And so I'm not going to go into detail there, but just know that before you can really engage in elective care or scheduled care, as I like to say, this gating system has to be fulfilled. Now, if you dive into it, you'll see a number of things that hold true to that theme of, is the pandemic behind us? Are the resources that we have been trying to preserve intact and being maintained intact? And so, I don't think there's anything here that's all that surprising, quite frankly. But I do want to call out two issues here. One of them is, when adequate testing is available, CMS is expecting us to test patients before care and also our staff on a routine basis. We're going to spend a fair amount of time unpacking that in just a couple of minutes because there's some problems with that. And then, as I've said, if a surge recurs in your locality, you can expect to be ramping down to allow the capacity to take care of COVID patients to develop. Now, one of the great things, it's been mostly bad news with the pandemic, but there are a couple of bright spots. And one of the things that has really impressed me is the leadership shown by anesthesia in general and our professional societies in particular. And so as the gentleman mentioned a few minutes ago, SAMBA released some guidance just a few days ago, basically with recommendations to tell us the things we need to be thinking about, the things we need to be doing as we reopen our centers in a safe manner. Now, I'm not going to go through this in detail. The document speaks for itself. It's in alignment with the other major professional societies, the ASA, APSF, the American College of Surgeons, and our partners over at ASCA. But it's a good place to start in terms of a tool to help guide you. Now, speaking of tools, I really think that you need to find a checklist, a reopening checklist, and apply it in a very rigorous way. Lots of health systems have developed their own checklist. In fact, this is on the right side of your screen where it says Health System Opening Checklist. That is the checklist my team at HCA, Dr. Rodriguez is part of that team, helped develop this. It's long, there are a couple of hundred elements in there, but that's our version. If you have something similar from your health system, by all means use it. But regardless, our friends at ASCA produced a fantastic reopening checklist. It's available on their website for members, and it's both of these are examples of Excel spreadsheets. There are lots of detail there. I don't want to scare you off. There's lots of detail there, but most of this stuff is already probably in place. But these checklists are just good tools to make sure that you have thought through all the contingencies about the status of your equipment, particularly if your center has been completely closed. And so if your center is up and running or close to up and running, going through this checklist will not take much time at all. And if you've been closed for a while, this will really be helpful in terms of making sure your permits and your water pipes and your HVAC systems, all of those things have been given thought. As an example of that, these are some of the broad topic items from our checklist that we're using in HCA in the ambulatory surgery division. You can see that there are things like the gating at the very top bullet point, initial tasks. That's a way for us to satisfy the request that the gating criteria have taken place. But you can, as you walk down this list, you'll see that we've pretty much covered all aspects of center operations, not just in the clinical realm, but on the business realm, the scheduling, and all of the things that it takes to reopen in a safe environment. I want to drill down a little bit for two reasons. One is to give you further example, and then another one that's frequently overlooked when people are developing new pathways and policies and procedures is they spend a fair amount of time thinking through how they want to do it. They may even spend a fair amount of time writing it down, but ultimately we're going to be held accountable for our performance, and that's either accountability can come from ourselves ideally, but it also comes from external forces like the government or accreditors. And so our friends at AAAHC have created a very nice crosswalk to help us in terms of, as you write policies, create the procedures, write the policies that describe them. AAAHC's checklist or crosswalk will allow you to map those things to the chapters in the accreditation workbook, so that when it's time for you to go through accreditation, you will have memorialized the things that need to be recorded. A prompt here is that also don't forget to get these things approved by the relevant governing entities within your ASC. So things go through the MEC and they'll have to be approved and adopted by your governing board. I know it seems kind of superficial, but once we get past this pandemic, let's try not to get ourselves in trouble when we get surveyed. Now, I want to turn your attention to the issue of workflows and efficiencies. I would strongly suggest that before you start taking care of patients at volume, now if you've been open and taking care of a few patients, a lot of stuff is still in place and you've probably figured out a lot of workflow constraints and opportunities. But taking care of 3 patients a day doesn't look like taking care of 30 patients a day. And so I would suggest that you convene your team and either run simulations of a busy day or do tabletop exercises where you talk through how things are going to be handled so you can identify issues before you've got patients in front of you. One of the hallmarks, the folks that I work who hear me speak about patient safety, they will recognize thematically that I believe we keep people safe by constantly looking for risk. And if we can identify and understand risk before it gets to the patient, then we have saved that patient. And so I think this is a perfect opportunity to do risk recognition before risk gets to patients. And I'll give you some examples in terms of opportunities. How you're screening patients. Now, you may very well have a very robust screening process in place, but this is a perfect opportunity to do more. Things like turnover times, how you're going to space patients in PACUs, those kinds of things are all important, and you can work through that now before you're actually faced with it. One quick word about the ramifications of this. We can expect for some time a different level of financial performance, and there are a variety of reasons. Our cases may be longer because of the infection prevention protocols, the intubation protocols that we have to do. Our supply costs are going to go up. N95 masks are more expensive than level 3 surgical masks or level 1 masks. Our cancellation rates may be different. And so financial performance in the old normal is not going to look like the new normal, and that's going to create some tension. Folks are going to think that I need to reopen, I have a budget, I need to meet the budget, and I need to do whatever it is I need to do to make that budget. Don't ever let that tension get in the way of taking care of your patients and your staff. And I know that's an obvious statement, but I'm already seeing across the United States that tension come into play. Let's talk very quickly about safety. There are two perspectives on safety I want to bring to your attention. One of them is the physical safety, and lots of folks have discussed that in the past. It involves rigorous attention to infection prevention, patient and staff screening, universal masking, and so on. But there's also a psychological component to safety. People want and need to feel safe. And so we have got to create a safe environment around them so that they feel safe and they will engage in our care and in our society. And I call out here the work of Dr. Amy Edmondson. And I think this is core for patient safety all the time, but in particular, and that is psychological safety is a belief that one will not be punished or humiliated for speaking up with ideas, questions, concerns, or mistakes. If you're going to have a rigorous infection prevention program, everybody in the building needs to feel like they can speak up if they point out an inconsistency or an opportunity to be more safe. I want to turn very quickly to the concept of COVID-free versus COVID-safe. Many of us are seeking to be COVID-free. We want to prevent the coronavirus from entering our building. That's a laudable goal, but I think it's an impossible goal. The harsh reality is, until there's a better point of care testing that we can administer immediately prior to the procedure to both the patient and the staff, or we have a great vaccine, or there's incredible herd immunity, we're never going to be able to guarantee a COVID-free environment. So we can work towards that, but we really need to focus on being COVID safe. How do you do that? Well, I'll give you a couple of examples of what we're doing in HCA. You can develop your own. You can certainly borrow from this. But we basically have centered around 4 pillars of infection prevention, access control, distancing, and patient flow. Probably all very familiar topics to you. Implementation at a detailed level of these things we believe will enable us to be operating in an enhanced protection framework. This is an example of a both patient and staff facing a summary of a COVID safe environment. It basically gives a little more detail about how we're trying to get there. I suspect that a number of you are saying, but Mike, I don't see anything on this COVID safe environment about testing. So let's talk briefly about testing. It's a conundrum, actually. The value of testing is dependent upon a variety of factors, but I'm just going to call out a couple of ones I think are relevant for this topic. The first one is availability. Now, some of you may be blessed to be in areas where COVID tests are readily available. they're inexpensive, and they're 100% accurate. I'm not living in that world, so we're struggling just with availability. Even when they're available, we don't really know what the accuracy is. And probably the third and most confounding part of this is, even if the first two are true, what is the likelihood that that test done in a moment in time, maybe 2 days ago, maybe 3 days ago, is valid the day that we're taking care of the patient? So as you think through your testing strategies, you're going to have to think about that, and whether you're going to impose self-quarantine on the patient and their family and those kinds of things, because the value of that test is only as good as the moment it was drawn. And in some of our markets, including the market in which I live, we're being told in our ASCs it may be 5 days before we get results back. And at some point, it almost doesn't make sense to even do a test, because so much can change, pardon me, in that interim. So as you develop your testing strategies, you got a couple of basic choices. You can test every patient, you can test selected patients. We've chosen this model in our ASCs. We're going to test selected patients based on the risk stature of the patient. So they're going to be high-risk patients, and then they're also going to be high-risk procedures. And those are examples of those would be aerosol generating procedures and those kinds of things. Or you could just say we're going to test no one and just go with maximum screening. I don't think anyone's choosing that pathway, but it is an option. But as I've said before, until we get a highly accurate, readily available, rapid return point of care test, we're going to be struggling with this for some time. Just as an example, this is a sample ASC testing algorithm. It's actually a draft of the one we're using in HCA. I'm not going to go into the details here. It holds thematically true to the strategy I just said about judicious testing. I'm happy to discuss it with you during Q&A or offline if you have an interest in it. Now, one thing I will say also on the bright side, I mentioned professional societies. We're starting to get more collaboration from the professional societies. And on the left side of the screen, you see an example of that, where the American College of Surgeons and ASA and AORN and American Hospital Association came together with a statement on restarting elective care. The American College of Surgeons is coming out with some guidance that's being incorporated by many folks. So that's a great thing. Now let me, in the last couple of minutes, touch on a couple of things. There are going to be a lot of questions, I know, about PPE. We can talk about that. You probably have algorithms about what a PPE is appropriate for what kind of person and what kind of case. I'm not going to discuss that here, but I do want to point out something. Whatever number you think you're going to use, you probably need to add an additional percentage onto that. Usage rates are going to be much higher than historical, and much higher, I think, than most people believe. And I can tell you in Dr. Rodriguez's my conversations within our health system, we're seeing that conversation every day. What's the supply chain say? What do we think we need? Those kinds of things. There are going to be lots of questions continuing around how we reuse and reprocess equipment. And then a key question, and no one has been able to answer this for me yet, but as we return to full scheduled care, under the old rules of engagement, there were certain rules that we followed, like single patient use meant we used the device for one patient. At some point, I suspect the world's going to say, guys, if you're going to be doing the same kind of work you were doing before, don't you think the same rules ought to apply as before in terms of masks and those kinds of things? I think at this point in time, we have a little bit of a pass, but at some point in time, I believe our PPE calculations and considerations are going to change. Another quick comment about supply chain. If your supply chain partner is not your best friend already, I would work very diligently to try to get that kind of relationship. Issue we face in the ambulatory surgery center business is that historical allocations for products like PPE are done based on historical usage patterns. And so we are now asking for supplies in numbers that we've never asked for before. And so that is upsetting, and I don't mean that on an emotional level, it's upsetting to the process for procurement for supplies. And so a lot of time needs to be spent educating folks about why we have these needs now and what we do. We seem to always have issues periodically with medication shortages. That's raising its ugly head again. And I would say, just in conversations with other colleagues across the country in multiple health systems, there's this tension again between how much PPE we have and what we need to be safe. And so do not let the amount of PPE you have available determine how you apply it. Start with the patient you have and what is needed to keep that patient and staff safe, and let that drive your PPE conversations. I think that's vitally important. Finally, a couple of clinical anesthesia concerns. I'm sure this is going to come up. We know some things about this virus, but there are a lot of things we don't know. I was just on a phone call with some cardiologists from around the country a few hours ago, and I was astounded at the cardiac presentations that are coming forth from a COVID infection. Folks are having sudden coronary events, they're having thrombotic events, and no one really can predict it, and no one really knows what to do about it. And then some of you probably have seen this study. It's small, I grant you, but some folks who unintentionally had scheduled or elective surgery in China turned out to be infected with the coronavirus and had some fairly catastrophic events, both in terms of rate and in actual outcome. So there's a lot to be done there. I think probably the call out here is we need to be hyper vigilant about following up with our patients, because there's a lot of noise, but there could be some signals in there as we start to re-engage in scheduled patient care. If you're seeing unexpected morbidity and possibly mortality, we might need to have a discussion as a profession. And then finally, as we move forward, a couple of broad things. There are going to be bumps in the road as we reopen. There are going to be continued surges, supply shortages, and evolving concerns and expectations. We just need to build that into our mindset and into our workflows. Kind of a global comment about healthcare in general, as Dr. Rodriguez said, I spend some of my time thinking about healthcare delivery in general terms, and I was a leader of a couple of large anesthesia practices for a number of years. I believe the American healthcare system is stressed beyond comprehension. No one ever thought we would be here. I believe we can expect thoughtful leaders to consider everything about the way they do business as being on the table. Current business models, delivery models, payment models, and people already are talking about abandoning historical relationships. I think the current financial stress that we face as an industry, as a country, is going to create an opportunity to have these conversations. And many of those conversations are needed and will be beneficial, but some of them may not be. And this pandemic turmoil will create political cover for those things to occur. And then the last thing I'll say is this. This is a challenge for us as an industry, as a profession, as ambulatory surgery center leaders, but I believe wholeheartedly this is our opportunity to shine. This is our opportunity to prove to the world that we are a great place for care, and that more care ought to come into the ambulatory surgery center environment. We just have to be able to deliver on it. And then finally, I'll leave you with this. This was from Peggy Noonan article in the Wall Street Journal just this past Saturday, and she was talking about reopening America as a whole. But this paragraph captures exactly what we're trying to do in ambulatory anesthesia care and in healthcare. And I quote, No one is certain what to do. Everyone's acting on insufficient information. No plan will come without cost. A lot will become clear in retrospect. The bias should be opening as soon as possible, as safely as possible. Don't sacrifice safe for soon. Have a solid, sophisticated, mature definition of safe. And then lastly, I need to thank my colleagues at HCA. I'm part of a great team there. They've contributed mightily to this presentation. And with that, I'll turn it back to you. Thank you.
Thank you very much, Dr. Hicks. Your presentation was excellent as always. And I have the honor that I listen to a lot of this almost every day because we keep rethinking what we're doing. I'm going to introduce now the next speaker. He's Dr. Stephen Geyer. He's a professor of anesthesiology and ophthalmology at the University of Miami Miller School of Medicine. He's the medical director of surgery at the Bascom Palmer Eye Institute in Miami, and is the chief of anesthesia services as well. He's the current chair of the Committee of Ambulatory Surgical Care for the American Society of Anesthesiologists. He's also the co-chair of the SAMBA Ophthalmic Anesthesia Committee, and he's a past president of the Florida Society of Anesthesiologists. Dr. Geyer and I have a very close relation. We've been friends for many years, and I've always considered him my consigliere. Dr. Geyer, go ahead, please.
Well, thank you very much for that really lovely introduction, Leo. And thank you, Dr. Hicks, for your highly informative talk. I want to add a few words about where I work. I work at the Bascom Palmer Eye Institute, which is a widely recognized facility for eye surgery, research, education, and physician training. It's been ranked as the #1 locale for ophthalmology in the United States by US News and World Report for over 16 years. Our main location is in Miami, Florida, and we have additional ambulatory surgical centers in Naples, Florida, Palm Beach, and Fort Lauderdale. We perform both basic eye surgery as well as serve as a tertiary care center, referral center for a wide area of the country. On weekends and holidays, and particularly during pandemics, when most ASCs have been shuttered, we're open for any emergent or pressing urgent eye surgery that needs to be done. And we've been doing quite a number of these cases in the past 6 weeks or so. I'd like to thank the Society for inviting me to speak this evening. And in particular, I'd like to extend my gratitude to both the President and the President-elect. I have no relative conflicts of interest. And the only pertinent disclosure that I have to make is that, like most of you, I'm ready to get back to work and work full time and doing what I love to do. So again, phase 1 was discussed on April 16th by President Trump and his task force, and they stated that it was time to start considering a path towards resuming scheduled surgeries. One of the things that was stipulated was a number of gating criteria, as Dr. Hicks showed us a few moments ago, and in order to open that gate, and so to speak, and get through the gate and get started. CMS also acknowledged that it's now time to start restart doing postponed cases in those regions that met the task force gating criterias. And so the ASA, the American College of Surgeons, SAMBA, and the whole host of acronym medical organizations agreed, came out with lots of statements, including the one that we showed you earlier from SAMBA, their statement on resuming ambulatory anesthesia care, which came out on April 18th. Now, I've highlighted just a few words from the SAMBA statement. SAMBA says that it's time to resume care of patients for postponed, time-sensitive, and elective surgeries as appropriate, with priority given to the former, the intermediate acuity procedures. SAMBA advocated for a stepped approach, which is certainly very, very prudent and wise. In places like Florida and in many other places around the country, there are further legal limitations on restarting. In Florida, the governor issued an executive order that explicitly quoted CMS saying that cataracts and lens surgeries are off limits. They're verboten. Our executive order does not expire until effectively May 11th. So in Florida, we have a few more weeks before we can consider doing purely elective type cases. And for now, we're limited to emergent and urgent eye surgery at our facilities. What I want to talk about today are what are emergent and urgent eye surgery cases, because there's a broad range to those. Just yesterday, our governor came out and signaled that he will probably allow the emergency ban on ambulatory surgical procedures to expire. He emphasized that the proposals are expected to mirror the phased-in approach offered by the president's task force. And he said, even if you could flip the switch, it's just not the way it works. And again, Dr. Hicks's lecture showed us that. He very, very ably showed us why you can't just turn on and start doing volume. You have to be selective. So let's be consistent with this stepped approach in Samba's statement. Currently, emergent and urgent cases, eye cases, are being performed in some ASCs, or they're being referred to regional centers such as ours in Miami, because the ASCs are shuttered, or they don't have testing capabilities or PPE, or have concerns over infecting other members of the healthcare team, etc. Now, pre-pandemic, elective cataract surgery constituted the great majority, or even the totality, of surgical eye cases at a number of ambulatory and surgical office settings. For these locales, phasing in and resuming surgery will have to wait till all the gating criteria are met and all the local restrictions are lifted. Now, for facilities that offer a greater breadth of ophthalmic procedures, the first steps are to identify those cases that have been delayed. Those cases that are urgent, but perhaps less time sensitive. They were delayed because delaying them didn't place a patient at their immediate health or safety or well-being at risk, or didn't contribute to worsening of a serious condition, or perhaps because there was an available temporizing non-operative option that could be selected in terms of medications, drops, pneumatic retinopexies, things of that nature. These kinds of cases are now coming due. They now need to be done. We're getting to that point, and we need to identify them. And as anesthesiologists who specialize in ambulatory care, we perform many functions that in hospitals are served by specific functionaries. In ambulatory, many of us are the administrators, the daily administrators, the gatekeepers. We work on scheduling, and we facilitate throughput through our facilities. We need to corral these less time-sensitive cases into some semblance of a staged gradual revival of a surgical schedule as we work through all the factors that we need to do to reopen safely, as described by Dr. Hicks, and also as earlier described by Dr. Phillips, ASA's president-elect at the ASA webinar. Now, Pritchard and colleagues have a paper that's in journal Pre-Proof from about 2 weeks ago, in which they delineated a scoring system to help guide case selection, so you can do this ethically, and you can ethically manage the scarce resources and the provider risks, etc. And this table from their paper shows that eye surgery cases are really ideally suited for the first phase launch. Our cases are outpatient, they're short duration, they're unlikely to be intubated, the patients, during surgery. Post-op ICUs not needed. Blood loss, essentially zero. And the surgical sites are not critical surgical sites. So these are the cases that society needs us to get done. Now, if we look at patient factors, we'll go from this slide very quickly, because of course our patients come with considerable chronic diseases. So we need to prioritize as we integrate medical necessity and time sensitivity. And what I'm offering here is to help catalog appropriate or potentially appropriate ophthalmic surgery cases to consider as we gradually gear up towards doing scheduled elective surgery. And of course, we recognize that when we talk about urgency, there's no fixed and strict guideline. You need to use physician judgment and take into account a variety of considerations. Broadly, the spectrum of surgical eye cases can be parsed into retina, glaucoma, anterior segment and or cornea, oculoplastics, oncology. For retinal emergent surgical indications, the kinds of cases that get referred to larger centers or are the ones that are actually now being done in ASCs that are open to do these cases, these encompass the fovea sparing acute retinal detachments, patients who are monocular, endophthalmitis, major bleeds, open globe injuries, and intraocular foreign bodies. Most of us consider intraocular foreign bodies as emergencies, and we can't imagine surgeons are holding off patients who have IOFBs waiting for the pandemic to pass. But in actual fact, that may be the case. During Operation Iraqi Freedom, soldiers were not treated on the field or anywhere in Iraq. They were actually shipped home to Walter Reed rather than having their surgery done locally. Mean time for IOFBs removals, instead of being a day or two or half a day or two, were 38 days, with a range of 2 days to almost 2 years delay before surgery. They had no cases of endophthalmitis because they treated everyone with antibiotics from the outset. And they found that the timing of vitrectomy did not correlate with the ultimate visual acuity that these patients, that these soldiers ultimately had. And in fact, it was just the correlating factor was the extent of the initial intraocular injury. So our retina surgeons may have some of these cases that should, of course, be our first priority to get these cases in if you're just starting up in low volume and trying to make ethical and moral decisions as to what to do first. Intermediate acuity retina cases include the ones listed here, macula detached retinal detachments, lens fragments, and vitreous hemorrhages in which there may be a retinal detachment underneath. Surgeons may be delaying these cases longer if the patient's intraocular pressure is within normal range, if there's no obvious decrement in status, if they've done temporizing things like pneumatic retinopexy, or if they're concerned that their patient may have signs or symptoms, or that they themselves may get it and they're reticent to do surgery. Again, these need to be prioritized. Then there are the less urgent, non-emergent surgical indications, but they are somewhat urgent still. The retina literature clearly defines these cases as needing to be done within 3 months. And right now we're in our 6th or 7th week. So I would imagine that there are a number of these cases, this volume that's pent up, that are not elective cases, that are not very urgent, but nonetheless, they still fall on the spectrum of being urgent. Macular holes, dislocated lenses, retained silicone oil, epiretinal membranes, traction on the retina as well. Now, glaucoma is quite a different thing than retina. With retina, we can get very specific and divide things in a programmatic way. But while some cases, glaucoma cases, are acute emergencies, most patients' disease is actually very slow to progress and develop. So it makes criteria for surgery less readily distinct. Glaucoma surgeons will integrate a number of factors, including intraocular pressure, whether medical therapy is effective, changes in visual field loss and how quickly those changes are occurring, and pain issues. They'll integrate those things to try to decide when it's time to do surgery. And the current crisis has likely promoted a much more conservative bias amongst our glaucoma surgeons. There should be a backlog of these cases that also have some degree of urgency to be done and can be justified to be done as you're starting back up again in your ambulatory surgery center. Anterior segment and cornea urgencies such as corneal transplantation and repair of corneal perforations and the like tend to fall into the emergency categories. Now, you'll note here I've included cataract surgery. Now, there are rare urgent and emergent indications for cataract. They are exceedingly rare, but they do occur, such as lens-induced glaucoma with angle closure glaucoma, or in the pediatric population, congenital cataracts during the amblyopic period. But there are also softer indications for, let's call it a pressing need to do cataract surgery. Patients who are monocular are at risk of accident. They're also could be compromised in terms of their ability to drive, read, care for themselves, do the activities of daily living. Also, anisometropic patients are patients that would be indicated to have more pressing need for cataract surgery. These are people that have difference in their refractive power of their two eyes. And why do they have that? Well, they've had cataract surgery on the first eye, and in the intervening time, we've come across this crisis. So they are walking around in danger to themselves, and one could make an argument that these are the types of cataract cases that should go first. In terms of oculoplastics and oncology, we are now started doing enucleation surgery for patients that have intractable pain that was not manageable by medical therapies or by injections. And we've also resumed inserting radioactive plaques for melanoma. It's no longer a watch and wait time. We feel justified that at this time, it's pressing enough to call them somewhat urgent. So in this time, I've attempted to briefly catalog what might be considered appropriate ophthalmic surgery cases that we should consider as we gradually gear up towards resuming elective surgery. There's a lot to ponder as we engage in collective decision-making and get things started. Once again, I'd like to thank SAMHSA and its officers for the opportunity to speak to you this evening. Good night.
Thank you very much, Dr. Geyer and Dr. Hicks. The two presentations were fantastic and phenomenal. Really appreciate it. Now we've got to 9 o'clock right now, which is the end of our webinar. However, because of the interest and the number of attendees and the number of questions we received, we have decided to expand and extend probably about 15 minutes or so. So if you have to get off the webinar, we do understand, but if you'd like to continue and join in the conversation and hear some of the answers from our speakers, that would be great as well. Just want to remind you that the webinar is being recorded and will be posted on our website in a day or so. So with that, let's start with the first question. There was a question about GI endoscopy. I just want to say we're going to cover that in the next webinar, so we do not want to use today's time in that. Next question, should we test nurses that have worked in the hospital setting prior to working at the ASC? Dr. Hicks, would you mind to take a stab at this, please?
Yes, and I will emphasize it's a stab. So I don't know that there's a correct answer here. The way I would walk through the logic is this. If the nurses were working in a hospital setting and were actively caring for COVID positive patients, I think, at least personally, the answer is unequivocally yes. They probably deserve a test, not just for the peace of mind of the staff and patients, but maybe for their own as well. But where this gets problematic is we have to kind of put the virus in perspective. And so what we know, and the data keeps changing, but what we know or believe is that for those folks who are going to become symptomatic, about 75% or so of them become symptomatic after about 7 days. And so if it's one thing if the nurse worked on a hospital floor or ICU yesterday, and another thing if they worked there 10 days ago. And so there's no hard and fast rule. I think in general, you got to use your good judgment. And as I alluded to, it depends on what kind of work they were doing and how long ago. That's how I would parse the answer.
Thank you very much. And speaking of testing, another question there. Since most locations may not have test capability by the time their facilities are planning to reopen, is there value in asking patients to remain in strict self-isolation for a certain period of time prior to the surgery?
Well, yes, I think my generic answer is yes, there is value. In fact, even when you're testing, as I said earlier in my presentation, that test is only as good as that moment in time when it was taken. And the longer the duration is between the test sample being taken and the date of procedure, the more opportunity is for that test result, particularly if it's negative, become invalid. So in those testing strategies, and I've looked at a number of health systems approaches to this across the country. Every one of them has said, get a test and then self-quarantine until the date of procedure. And so if you're not going to test, I would fall back on the latest data and say, at 7 days, for example, you can feel pretty good that 3/4 of the folks are going to be symptomatic if they're positive. So to kind of sum it up, yes, I think there's some value, but that's a qualitative answer, and I don't know that we know enough yet about this virus and many unknowns to give you a quantitative answer. But in general, what people have been using for the workforce in terms of return to work is 14 days. And so I think that's a safe answer. Self-quarantine for 14 days is what we've been doing. Anything less than that, it's a probability game.
Thank you. Dr. Rodriguez, there's a long question here. I want to summarize it in the person who asked the question is questioning the statement, the SAMHSA statement, where it talks about level 3 masks in all clinical areas. They're wondering if that's really necessary in pre-op and PACU in an ambulatory surgery center or office-based anesthesia practice where there's nobody on oxygen or have any airway in place and such. Would you like to comment on that, please?
Yes. So I'd like to first start the answer by highlighting what Dr. Hicks said in his presentation, that we're not going to live in a COVID-free environment. We're going to live in a COVID-safe environment. And being in a COVID-safe environment includes the use of PPE and also the use of continuous masking inside the facility to prevent the contamination from one patient to another or from a patient to a nurse. There's a question about the type of mask that we spoke about in the statement, and just to explain things very simply, the procedural mask is what we call a level 1 mask, and a surgical mask is what we call a level 3 mask. And when you're differentiating a mask from another type, you're using the ASTM classification, and they consider 4 different things. One is filtration, second is fluid resistance, and then there are certain features on the way the mask is attached, and whether they have foam or tape, do they have shields in the eye, and then the fitting of the mask. And basically the difference between a surgical mask and a procedural mask is the ability to withstand fluid. And the problem is that when a patient has surgery, for instance, under general anesthesia, or when they have an upper endoscopy and they come out of the procedure, these patients could be nauseated, they could be coughing constantly because of airway irritation, and if they're patients that are carriers of the COVID virus, they're going to be coughing and they're going to be exhaling the COVID virus in the droplets. And by having a level 3 mask, you're containing that virus inside the mask and you prevent the aerosolization. There's a manual that was published by OSHA, CDC, NIOH, that talks about the use of masks for respiratory prevention. And I posted this manual on the April 22nd webinar in the QA questions that we have a forum where people can go, and the reference is there if they want to read it completely. But basically, in this reference, on page 6, I'm going to tell you which page to read, and in page 9, they talk about the protection of the staff from the patient's droplets with the use of a surgical mask. And that's why we included that in the statement. Now, if you're doing an EGD inside the procedure, everybody's expected to be wearing an N95 mask, and that's a different issue. But to protect our nurses who will be wearing a mask all day on their face, this mask is going to get humid with their breath. And I recommend the use of level 3 for them to prevent them from their mask getting wet and losing its properties. And then it increases the risk of getting droplets inside their face. We're keeping a distance, and that's why we're using this type of mask. But please go to the Samba Clicks website where there's more extensive answer in writing.
Thank you, Dr. Rodriguez. So if you go to COVID-19 resources page and click on the forum, you'll find all these answers that Dr. Rodriguez was talking about. Some of these questions are listed there, and you can post your own question as well. This is access for members and non-members during this COVID crisis as well, so free for all. Question for Dr. Gayer: can we resume eye surgeries with no PPE?
Well, I would, my personal opinion is no, that PPE is here to stay. Remember that coronavirus has been isolated from tears, and I'd like to think that when I do an eye block, the patients never tear or cry, but tears, you can encounter tears. Sometimes patients sneeze after an eye block. It would behoove you to wear PPE for a regional anesthetic of an eye, and during surgery as well. I'm of a certain age that I was around when HIV first started, and at that time, a great number of our older colleagues were not using gloves for IVs, for arterial line, for intubating. These are things we wouldn't even think of doing today, right? It's de rigueur to use gloves. I think that PPE is here to stay.
And the second part of that question is, assuming we have no testing established preoperatively, what about when placing the nasal cannula? Is there a risk for possible transmission of the COVID-19 virus? I think they're talking about the aerosol generating procedure type of deal. Would that be considered one of them if you give oxygen through nasal cannula for sedation, anesthesia with eye surgery?
Well, again, as with anything that we do, oxygen is a medication that we prescribe. We tend to sometimes overlook that, but it's a conscious decision of what we do. If there's concerns and the patient has no indication for oxygen, perhaps one consider not giving oxygen. You certainly want to avoid high flow nasal oxygen. That's certainly not advisable. But 2 to 3 liters per minute is probably acceptable, especially when you consider that we're going to cover the patient with drapes. We could put suction cannula underneath the drape as well, and take other precautions.
Thank you. The third part of that question, do I need to ask all providers to use N95 masks for these cases?
I think, yes. I mean, that's the answer is, if it were me, I would want to have an N95. But the general guidance that, I mean, the way, I think there's a bigger question embedded in this. And so the general way we've been approaching the use of N95s is that there are high-risk patients and there are high-risk procedures, as I said during the presentation. When it comes to categorizing those, we just settled on this today, as a matter of fact. Anyone who is manipulating or in and around the airway is in a higher classification. And so it's been a number of years since I provided clinical care for eye surgery, but unless it's changed markedly, you've got several people in close proximity to the airway. And so that kind of raises the ante a little bit. And then the next filter we have is there a low likelihood for secretions and aerosolization, or a higher likelihood? Unless you can assure me that that patient is not going to cough or sneeze, and you can assure me that that patient is COVID free, which you already know my position on that, then I believe an N95 is indicated if you're that close to the patient's airway.
Thank you. Next question, Dr. Rodriguez. In general anesthesia cases, how many people are to be in the room at once? Only anesthesia in the room for intubation? Or what is considered essential personnel for intubation and extubation?
This is a question that comes up a lot. And, some people, because they're trying to preserve PPE, they're trying to limit the number of people in the room, but we have to think about patient safety. So imagine if you only have one anesthesiologist in the room doing the induction of anesthesia by themselves, and they drop the tube on the floor, or their medications are dropped. So you always need to have additional personnel. And at this time, if we use allied health providers, we can have the allied health provider, the anesthesiologist. If it's only anesthesiologists in the practice, it could be 2 anesthesiologists in the room. And I would also add a circulating nurse wearing also an N95 mask if we're doing an aerosolizing procedure, because they can help us with the suction. They can help us with getting certain equipment that anesthesiologists don't typically have in their cart, and that we may need urgently, or go outside and get the glide scope or something else. So I would advise to at least have an anesthesiologist and a circulating nurse, or an allied health provider and an anesthesiologist plus the circulating nurse, or 2 anesthesiologists and the circulating nurse, because it's all about safety. And if you get into an emergency, that's not the time to call somebody from the hallway to help you, and now they have to start wearing the mask and the gown and the gloves and the face shield.
Thank you.
Leo, Bassem, can I add something to that? One thing I've noticed that is frequently overlooked, and so I agree, as usual, completely with Dr. Rodriguez, but I would go a step further, and I believe, at least for the time being, an essential part of the crash cart should be PPE, because on those rare occasions where it all goes to pot, and you need a resuscitation team in there, the last thing you want to do is put them in a position where they have to either come in unprotected or run through some other part of the building to find PPE. So I think every crash cart, in my opinion, should have a couple of N95s, a couple of face shields, a couple of gowns, just like it has epinephrine and those kinds of things.
I could not agree more. This morning, a circulator nurse called me to help out with a situation in a room, and I was already prepared with my mask and so forth. So that was helpful. I was able to help out. So to have an extra person to be able to call for help when needed and so forth is important for these situations. Should we plan on testing every patient and employee prior to resuming elective surgery at ASC? I think you answered that a couple of times, but just quick, real yes or no, and we'll move on. Should we plan on testing every patient and employee prior to resuming ASC?
Once again, this is a case of there is no right answer, and I'm seeing everything you can imagine across the country. So if you can do it, it's probably a good thing. But if you can't, I wouldn't worry about it.
I think there's a question here about, is there any protocol for the reopening of surgery center? I believe you answered that during your talk, so we'll move on to the next. What kind of modification to my anesthesia machine, if any, do I need to make sure we have in place prior to opening? I have a Mindray A3.
Yeah, so
Dr. Enriquez? Yes.
that's actually the same machine that I use at my facility. And what you need to think about is protecting the patient and protecting the anesthesia machine. So the APSF has a web page dedicated to what you should do to the anesthesia machine, and it actually contains a table with all the different brands of anesthesia machines and the models. So you can actually click on the links, and it'll take you to the proper web page for your machine. What I've been doing at my facility is I use the filters that are 99.9999%, which means that it protects from viral particles and even prions. And I put one on the Y before going in contact with the patient. The filter that I use in particular also has a CO2 line on the filter. So what happens is I'm protecting the the CO2 gas, because in some machines that gas is being remixed again with the guy the gas that's recirculating through the machine. And then we should
Yeah.
also put an expiratory limb, another one of those 99.99% filters to protect the machine. That filter attached to the machine does not have to be changed for every single case, but the one on the Y piece does have to be changed
Well,
for every
you
single
kind of
case.
answered thank you. You kind of answered the next question, but there's a follow-up to that. The end-tidal CO2 water trap, should we change that after every case? And what about the CO2 absorbent?
Uh, Actually, no, because remember, we're putting a filter of the gas that's coming back to the machine, and the filter that we're recommending that people use are the ones that are on the white piece, and they have a port for the CO2 line on the side that's clean, so that we don't have to be doing that extra work of changing those lines.
Thank you. There's a question about, do you have any special advice for elective dental procedures? For the person who asked that question, I would refer you to the Society of American Dentist Anesthesiologists. They issued a very nice statement that I thought was very, very helpful. The next question is that, what are your feelings about doing elective ENT cases when you reopen, especially airway cases? If you elect to do them, do you need pre-operative COVID testing? Anyone would like to take that, or I'm happy to take care of that one. In our facility, for example, we test every patient who's coming for ENT airway procedure as well as bronchoscopy procedures. It's kind of aerosol generated procedures, and we take care of them cautiously. And the anesthesiology team, anesthesiologists, CRNA and/or residents, as well as the surgery team, all were N95 for these kind of cases. Pre-op testing in all PEDS patients, what would you say to that, Dr. Hicks?
I'm sorry, could you ask that again?
Pre-op testing in all PEDS patients?
Yeah, I'm not sure I understand that question.
Pediatric patients, would you test them all?
No, we're testing only patients having high risk procedures, just consistent with the answer you just gave.
Got it. Thank you very much. Some suggest no mask induction, only IV inductions, placing an IV on an awake younger kid. Not to mention a moving target leads to crying and screaming, which to me cause spewing of secretions. I will take the liberty of postponing the answer to the question to the next webinar, where we're going to address pediatric issues with that. Well, folks, we got to 9:20, so I think we thank you for your patience and for staying with us. We have a few more questions. We're going to do everything possible to answer them and post them on our website in the frequent asked question section, or possibly also on the forum. And I would like to get your attention to that forum, where you can go post your question to all your colleagues in the SAMBA atmosphere. They're all going to get email with your question, and all going to contribute to your answer and share with you their best practices in their areas. Well, thank you all again for joining us tonight. Please mark your calendars for next Monday webinar. And before I close, I'd like to say big thank you to our speakers, Dr. Hicks and Dr. Garan, our moderator, and President-elect Dr. Rodriguez, for your awesome presentations, very informative, and your very thoughtful answers. With that, we'll conclude tonight's webinar. Wish you all good evening, stay safe, and God bless. Take care.
Thank you.